Have you ever heard of malaria? History. Over millennia, its victims have included Neolithic dwellers, early Chinese and Greeks, princes and paupers. In 20th century alone, malaria have claimed between 150 to 300 million lives, which is 2 to 5% of all deaths. On 20 August 1897, Ross discovered and proved the role of Anopheles mosquitoes in the transmission of malaria parasites in humans. Its chief sufferers today are the poor sub-Saharan Africa, Asia, the Amazon basin, and the other tropical regions. 40% of the world's population still live in areas where malaria is transmitted.
Epidemiology. The first exposure to malaria occurs very early in childhood, and with the repeated exposures, the likelihood of severe illness or death lessens. In Africa, where the majority of malaria-associated deaths occur, the highest mortality rates occur in children less than 5 years old. Malaria-associated mortality decreases rapidly with increasing age. Due to lack of acquired immunity, displaced populations coming from areas of little or no malaria transmissions to areas with intense transmissions are therefore at greatest risk of severe illness and death. Malaria also has important effects in the way of chronic or repeated infections, including anemia and poor pregnancy outcome. The malaria parasite life cycle involves two hosts. During a blood meal, a malaria-infected female Anopheles mosquito inoculate sporozoites into the human host. Sporozoites infect liver cells and mature into zygotes, which rupture and release merozoites. Hypnozoites, which is a dormant stage in P. vivax and P. ovales, can persist in the liver if untreated and cause relapse by invading the bloodstream weeks or even years later. After this initial replication in the liver, exoerythrocytic schizogeny A, the parasites undergo asexual multiplications in the erythrocytes, which is erythrocytic schizogeny B. Merozoites infect red blood cells. The ring stage tropozoites mature into zygotes, which rupture, releasing merozoites. Some parasites differentiate into sexual erythrocytic stage, which is gametocytes. Blood stage parasites are responsible for the clinical manifestations of the disease. The gametocytes, male microgametocytes and female macrogametocytes, are ingested by an Anopheles mosquito during a blood meal. The parasite's multiplications in the mosquito is known as the sporogenic cycle, while in the mosquito's stomach, the microgametes penetrate the macrogametes, generating zygotes. The zygotes in turn become motile and elongated, which invade the midgut wall of the mosquito, where they develop into oocysts. The oocysts grow, rupture, and release sporozoites, which make their way to the mosquito's salivary glands. Inoculation of the sporozoites into a new human host perpetuates the malarial life cycle.
Pathogenesis and diagnosis. Pathogenesis of malaria begins when a person is bitten by an infected female Anopheles mosquito, and Plasmodium species parasite in the form of sporozoites are injected by the mosquito into the person's bloodstream. Then, the sporozoite will travel to the liver, multiplying asexually for the next 7 to 10 days, and there are no symptoms occur during this time. Now, the parasite in the form of merozoites emerge from the liver cells in vesicles and travel through the heart and to the capillaries of the lungs. The vesicles will eventually disintegrate and releasing the merozoite to enter the bloodstream, where they will invade and multiply in erythrocytes. When the cells burst, the parasite will invade more and more erythrocytes. The symptoms that occur during this time, including fever, which occur in sync with the structure of infected erythrocytes, and the release of its debris, also the malaria toxin. The other associated symptoms of malaria are severe anemia, fever, chills, vomiting, muscle ache, anorexia, abdominal discomfort, and many more. Diagnosis: examine a drop of patient's blood under the microscope. The blood is spread to create a blood smear on a glass slide to be viewed under the microscope. The specimen is stained, commonly by ginsta stain, to give the parasite a distinctive appearance. Malaria is treated with prescription drugs to kill the parasite, but the types of drugs and the length of treatment will be vary depending on which type of malaria parasite you have, the severity of symptoms, age, and whether you are pregnant or not. The most common anti-malaria drugs are artemisinin-based combination drug is chloroquine phosphate, combination of atovaquone and fluguanil, which is Malaron, quinine sulfate, which is qualaquine, with doxycycline, which are bibramycin, Molodox, and others, mefloquine, and lastly the bramaquine phosphate.